Hi, everybody. Welcome to our Telehealth 101 webinar. Just a couple of announcements here as we get started. A reminder that the 2021 Flex virtual reverse site visit is coming up July 20th and through the 22nd of 2021. So that's this coming July. The theme this year is rural resilience for healthier communities, and the request for proposals period is currently open. So if you're interested in that, you can go to our website and submit a proposal. Think about all that awesome good work you guys have been doing. You always do good work, but it's been just even more kind of crazy making in the last year or so. So think about what you've been doing that your peers might like to hear about. We also have the TASC customer satisfaction assessment that was launched last week. We're looking for feedback from each state flex program, so please complete that by March 5th. And then also the spring flex program workshop is going to be held starting at the end of March, and you can see the dates and times on the slide there. If you have somebody new working with your flex program and are interested in having them participate, reach out to Andy Naslin to let him know that you're interested in that. Put up the polls. Okay, so if you all would just take a few minutes to answer these two polling questions before we present our content, that would be great. So this is the first of a 5-part series of webinars that we're partnering with the Telehealth Resource Centers on, and the other dates will be coming soon. Topics will include telehealth policy, virtual primary care, telemonitoring of rural patients, and tele-behavioral health. Are you guys seeing the polling questions now?
Yep, got them now.
Okay, great, thanks. So today's webinar, Telehealth 101, features staff of the Northwest Regional Telehealth Resource Center, and they are going to describe some basics, including definitions, modalities, payment, workflows, and technology. They're going to share a bit of information about current telehealth regulatory changes and waivers during and post-COVID. They're going to talk about some ways that flex programs can support the telehealth needs of critical access hospitals and rural health clinics. Share at a kind of a high level how increased telehealth use could impact finance and quality measures in the movement to value-based care and population health for critical access hospitals and rural health clinics. And that's something that we'll talk more about in a virtual knowledge group call in March, just so you know that that's coming. We'll let you know the date as soon as we have that all figured out. And then also share some information about the role of the telehealth resource centers. So our speakers from the Northwest Regional Telehealth Resource Center, Matt Mccullough. Matt is the principal investigator and associate director of the Utah Telehealth Network. Matt was previously the director of the Utah Office of Primary Care and Rural Health, where he worked closely with healthcare providers serving rural and the underserved communities and gained extensive grant management experience. In his spare time, Matt's working on a PhD in medical geography. Nicole Parisho, program director. Nikki is most recently served as virtual health manager at Kalispell Regional Healthcare in Kalispell, Montana, where she experienced a telehealth surge due to COVID-19. In a very short period of time, Nikki designed and implemented a direct-to-patient in-home delivery model for over 700 clinicians and outreach clinics, expanding telehealth visits from 22 per day to more than 350 per day. From her clinical background and years of telehealth experience in multiple specialties, Nikki has firsthand knowledge of the needs of healthcare providers and patients and how those needs translate into best practices for telehealth. She also has a regional perspective, having served on the Northwest Regional Telehealth Resource Center Advisory Board and the Montana Telehealth Alliance. And also joining them is Jolene Johnson. She's a programs manager and joins the team from the University of Utah Health, where she was the telestroke program coordinator for 5 years before being promoted to neurosciences outreach administrative coordinator. She coordinated a telestroke network of 27 sites in 6 states, managing the daily operations, providing support and training to sites and physicians, working through administrative challenges such as licensing and credentialing, and tracking quality metrics. So with that, I will stop sharing and let Nikki share her screen and go ahead and get started.
Thanks, Nicole. So thank you for that warm welcome and giving us the opportunity to present today. I'm going to hand it over to Matt to start out our presentation, and I'll be back with you shortly.
Okay, thanks, Nikki. Yeah, and thanks, Nicole. It's great to be with everybody. It's fun to be back with the TASC group and the FLEX programs. I really enjoyed my time working in the FLEX program. So Nikki and I represent one of the regional telehealth resource centers. There's 12 of them, if you're not familiar with them. We cover 7 states in the Northwest region, and obviously a very big geographic area, very diverse region, all the way from Utah to Alaska. So we've got our hands full covering that big area and helping support providers and organizations who want to implement successful telehealth programs. We are part of the national consortium of telehealth resource centers. So the 12 regional centers and the 2 national centers that cover policy and technology. We all work together as the national consortium to put on webinars such as the Hack series that's going on right now, and produce other resources that are available on our website. So that's a little background of who we are and our region. We just launched a new website, and it's really easy to find the regional telehealth resource center for your state. But we all work together, so if you reach out to us, we're happy to put you in contact with the resource center for your state as well. Nikki is actually going to take charge now and cover the Telehealth 101 piece.
Thanks, Matt. All right, so as Nicole already explained the objectives, so I'm going to skip right over this slide and we'll jump right in. So telehealth is defined by HRSA as the use of electronic information and telecommunication technologies to support long-distance clinical health care, patient and professional health-related education, public health, and health administration. These technologies include video conferencing, the internet, store and forward imaging, streaming media, and terrestrial and wireless communications, all which we'll talk about. So basically, what is telehealth? What are the modalities of telehealth? In 2019, CMS, the Centers for Medicare and Medicaid, made the administrative decision to significantly expand their reimbursement for remote communication technology-based services within the Medicare program. These are services that are not technically defined as telehealth within Medicare because they don't have an in-person equivalent, and then therefore they are not limited by those limitations and restrictions that apply to telehealth services. So that's the remote communication-based technologies. Live video, synchronous telemedicine is what most people are familiar with when they hear the term telemedicine or telehealth. And telemedicine and telehealth are used pretty interchangeably. Telehealth is a little more encompassing, where it addresses maybe education that is provided over video, or telemedicine strictly was more of a provider-patient interaction. So live video is referred to as synchronous, and this is actually using a secure HIPAA-compliant audiovisual telecommunications technology to have a connection between a provider of some sort and a person, whether that's a patient or a caregiver. This may substitute for an in-person encounter if that in-person encounter is not available. Audio only is referred to a visit that just is a phone call or some sort of voice only without the video. We'll get into this a little bit more, but prior to COVID-19 and the waivers, this was not recognized by CMS and therefore was not reimbursable. Store and forward is also referred to as asynchronous. These technologies allow for the electronic transmission of medical information, such as digital images, documents, pre-recorded videos that goes through a secure email communication. Some examples of this could be an EKG, if you have a rash and you take a picture, or if you're post-op and you want to share something with your surgeon, that would be the type of modality of telehealth that you would use. Mobile health, or mHealth, is the provision of healthcare services and personal health data via mobile devices. So nowadays that is Fitbits, Apple Watches. The new Apple Watch that just came out, the 6, has an EKG technology embedded in it, so the wearer, if they're feeling something abnormal in their heart, they can actually touch their watch with their finger, their pointer finger, and their thumb, and take an EKG that is the same quality as you could get at the bedside. And then finally, remote patient monitoring, or RPM, which uses digital technologies to collect medical and other forms of health data from an individual in their home or in their vehicle if they're not at the hospital or in a clinic. And this electronically transmits that information securely to their healthcare provider. And this image on the screen, this is some examples of devices that could be used for remote patient monitoring. So there are pros and cons of telehealth, just like everything else. So really, I think one of the biggest pros to telehealth is it improves access to healthcare. And I think COVID has really showed that it is a validated model of care. I think that payers are recognizing that, the federal government's recognizing that, providers are recognizing that, and patients. And it's really being adopted by all of those groups. It decreases the transmission of COVID-19 or other communicable diseases. It reduces unnecessary provider and patient travel costs. I know, so I'm located in Montana, and we have a wide geographic spread, and a lot of times organizations or clinics are sending providers to rural areas to have outreach clinics, and this kind of decreases the need for that. And also patients. A lot of times patients are traveling to far areas, they're taking time off work, they're taking their kids out of school, maybe they have to spend the night, so they have lodging and food costs. And then there's the other non-tangibles like inclement road conditions. I mean, I know Minnesota, Montana, you're dealing with weather and ice. And then here in Montana and in the Northwest, we have bear and elk and other wildlife that can definitely propose a barrier. Telehealth definitely can address healthcare provider shortages. And then again, patients that live in rural and underserved areas have this increased access to specialty care. On the flip side, the cons, licensing and credentialing by state. And I'll get into this in just a little bit. I'm not going to spend too much time on it here. Uncertainty of HIPAA compliance and the technology. This is a huge one. Given the waivers, that is one of the regulations that was loosened, was that it was not necessary to conduct a telehealth visit using a HIPAA compliant software. So I think the only two that were not allowed were I think FaceTime Live and TikTok or something. So being a clinician, this one really sticks with me. Another con could be lack of provider and staff training. Telehealth is not an inherent skill. Everybody's made the change to these virtual meetings, and so people are more comfortable now than ever, I believe, with technology. But it's still something that that needs workflows and training and competencies and follow up. Lack of broadband connectivity and the ability for your patient to connect. Prior to COVID-19, patients were usually having telehealth visits from a clinic in their local community, but now really patients have the opportunity to be in their home, which presents a whole new boatload of challenges that we'll touch on in just a little bit. The lack of patient education and knowledge around telehealth, and then also concerns around reimbursement. So workflows. Hospitals and clinics in your state may have kind of stumbled upon workflows as an important element of making a telehealth program or visit successful. So as Nicole mentioned in my bio, I had worked for an organization, and during COVID-19, we had to pivot quickly, as many hospitals and clinics in your state did, I'm sure, on how to get patient access in their home. And really, what was determined to be best practices was create workflows that are specific to that clinic or hospital's practice and the telehealth and the specialty area that they're delivering care. It's up to a provider to determine which patient is a correct patient for telehealth. As we know, not all patients and chronic diseases and management are appropriate for telehealth. So once the provider identifies that patient, the next step really, I think, relies on the kind of support staff in those clinics or hospitals. And it's up to them to make that connection with the patient once they're deemed appropriate. And this person or team really should know the telehealth program that they're using. They should be comfortable with the technology, they should be comfortable with the terminology, and also understand what needs to take place for that telehealth visit, because they're that first contact with the patient. And the patient really, they're asking the patient if they're open to a telehealth visit. And in some cases, they're telling this patient what telehealth is for the first time. The patient may not know this. And then at that point, they'll ask if they have, an internet connection. And if that internet connection is strong enough to stream a movie or a video, because a lot of times the patient won't understand internet strength or broadband or data. And so the next question then is, do you have an email address? And do you have a device that has a speaker and a camera and a microphone? All of these things that to somebody who's doing telehealth all the time, it may seem inherent, it may seem like common sense, but to people that, and patients that it's not their world, it's not. And then also to test that connection prior to the appointment, just to make sure that there aren't any barriers that are unforeseen, to save frustration on both the provider and patient end when that visit comes to fruition. I say website manner, and this is really just so the provider or the healthcare clinician that's having the telehealth visit is aware of their setting, their background, privacy. Is their door to their office closed, or if they're in their home, or are they in a quiet area that's not cluttered? There's not a lot of disturbing background light to distort the image, and all of those things are really important education ahead of time. Patient etiquette, this is one that really has popped up since COVID-19. And prior to COVID-19, I'll be honest, well, usually patients weren't in their home, right? So we don't really have to worry about this. But it's really important to educate the patient that they should be in a private area. They should not be driving their vehicle. They should be fully clothed. These are some actual feedback stories we've heard from real providers doing real telehealth visits. And it's really distracting and hard to have the visit when the patient isn't in an appropriate setting. Another thing in terms of workflows with telehealth is if the patient came into your clinic for an in-person visit, when they exit the clinic, that's when they get all of their information on follow-up appointments, labs, referrals. So it's important that there's a workflow in place that the patient knows what they need to do following their visit. And then finally, on our website, we have a tool, we have 2 documents for patients specifically. One is like a patient readiness checklist. So it determines what the patient needs to do to get ready for their telehealth visit. And then also 20 things that you should know about a telehealth visit. So just kind of some education for patients and consumers. The technology that should be considered with telehealth. So a lot of hospitals and clinics in your state may have had platforms, and a platform is the modality where the telehealth is being performed. So right now we're on a Zoom call. There's a video, which is very similar. There's DoxyMe. Those are all different platforms that providers can use to for their patients to access them. Broadband and high-speed internet access definitely affect the access and availability for a telehealth visit. With, as I noted before, prior to COVID, patients had to be in a clinic to have these visits, but now they're in their home. And so, the FCC and states and the federal government has done a lot of work to get broadband and high-speed internet to clinics, to the door, but not so much to get it to patients' homes. So that's really one of the biggest challenges now is patients are in their home, they don't have good connectivity. What are we going to do? So COVID-19 and a lot of the CARES funding that originated from that, we've seen a lot of creative connectivity solutions. We've seen a lot of clinics and hospitals saying, well, we want to provide telehealth, but we can't reach our patient because our patient doesn't have internet or doesn't have connectivity, or they don't have a smartphone or a tablet. We have in Montana, we have a lot of tribal population, and really all they have is sometimes a landline, and that's the reality. And so a lot of hospitals and clinics have created programs and purchased devices with funding for patients to come to maybe to their parking lot, and they have staff go out and give them an iPad or a device, and then following the visit, they get it back and they sanitize it and they go on to the next patient. And then also around platforms, this HIPAA waiver and the business associate agreement, if a hospital or clinic is partnering with a vendor for a platform, it's really important to have that BAA in place because that is what makes it a secure HIPAA compliant platform. And I know that there's a waiver right now disallowing that piece, but I think in healthcare that's a really important aspect of telehealth. Another form of technology that's available in hospital and clinics is video that's embedded in the electronic health record or the EHR. So Epic, Meditech, a lot of the bigger EHRs have kind of a telehealth platform embedded inside of it. So the provider is able to see the patient and split their screen and see the patient's chart, and the patient would receive the invite for their telehealth visit through the portal, and that's how they would access their visit. Again, those remote patient monitoring devices and then peripherals. So the remote patient monitoring devices, Matt will talk a little bit more about this, but it really helps to decrease readmission and with those chronic diseases to stay on top of medicine management, medication management. And this is where the actual, for a blood sugar reading or a weight for a congestive heart failure patient, that will come right into the patient's chart, and then the provider can assess it. And then again, those peripherals, those different stethoscopes, otoscopes, thermometers, different external measurements that can be connected by either a USB or a Bluetooth connection. So I'm only going to touch very briefly on this. Mei Kwong in the Center for Connected Health Policy is going to do a whole presentation on it. But I just wanted to address some of the telehealth policy changes that have come across in COVID-19. I know I've mentioned a few of these during my discussion thus far, but on a federal level, since COVID-19, since the original waivers were in place, they waived those geographical and site limitations. So prior to COVID-19, CMS outlined in their MLN, they have an annual telehealth guide that comes out that a Medicare patient, in order to have a telehealth visit, needed to be in a health professional shortage area and in a rural area. And then they had to be in a certain kind of clinic to be qualified as a patient for a telehealth visit. That has been since waived during the PHE. If that will stay that way permanently or not, nobody knows. That's a very hot topic. Some states have already made permanent changes to disallow those, but we'll have to just wait and see what happens. The type of providers that can provide telehealth has been expanded. They've waived certain limits around those visit types. Modalities, like I said, they've accepted a phone call and audio only as an acceptable visit, and also some services. They relaxed some of the supervision requirements, and then licensing has been relaxed in some areas as well. They've, as I said too, they've added 80 additional service codes, and they've also expanded to allow therapies, physical, occupational, and speech language to use telehealth, which has just been extremely exciting and rewarding. And actually the telehealth hack on March 10th is going to talk about rehabilitation via telehealth and early interventions. The state, Medicaid, some of the changes, again, the modalities are allowing phone, they're allowing home as a originating site or as a location site. They've relaxed some of their consent for telehealth services. They too have expanded services, and then they're also allowing other providers. And licensing is a huge issue because each state medical or licensed provider specialty is different. So really the best way to know what the licensing is for the state where your patient is located is to check with that state's medical licensing board. Some permanent state telehealth changes since COVID, July through August of 2020, 31 states have made permanent changes. Some of these have been done through administrative channels, not necessarily legislation. And it's really not clear as if they were done in response to COVID or if they had been pre-planned. And permanent state telehealth changes. So several states have adopted the policy of the audio-only reimbursement in Medicaid, but they have a narrow set of services. There's been clarification that home is the eligible originating site, and they've clarified policies around FQHCs and RHCs in Medicaid. So Hawaii, they have identified those as eligible providers. West Virginia, they've allowed psychiatrists and psychologists to be eligible distance site providers that are in FQHCs and RHCs. And then an FQHC is a federally qualified health center. And then of course, rural health clinic. Sometimes I forget about my acronyms. I just assume in my old role, we used to be fined $1 if we did that, but I'm sure you guys are gonna let it slide. And then Wisconsin will allow full PPS rate reimbursement. I want to share some telehealth resources with you all. So the NRTRC has recently partnered with some organizations to provide telehealth training. The state of Washington, starting January 1st of 2021, passed a bill that mandated any licensed practicing healthcare professional needs to take a telehealth online training course. And so the Washington State Telehealth Collaborative partnered with the NRTRC to create that content, and it's housed on our website at nrtrc.org. And this is just a kind of high-level overview of all the nuts and bolts for telehealth. And at the end, there are CMEs available, and at the end, after your successful completion, you're awarded a certificate that states that you've taken the course. The NRTRC also offers a Telehealth 101 online training, which is a module of 6 courses, also CMEs. And then finally, we have partnered with the University of Washington and Harborview to create a Tele-Behavioral Health 101. So this is specific for mental health providers. This is 6 courses as well and allows for CME. The National Consortium of Telehealth Resource Centers, as Matt introduced in the beginning, we are a part of. They have excellent sources. They just did a white paper, and their website is telehealthresourcescenter.org. The Center for Connected Health Policy, where I shared some of those policy changes on both the federal and state level, I believe they're doing the next webinar in your series, and they're a CCHP, and they're great for anything on policy. And then finally, the National Telehealth Technology Assessment Center, TTAC. This is part of the National Consortium as well for information on technology. And just real briefly, I'm going to leave this up. You guys will get a copy of these, so I'm not going to go into all of these funding opportunities. You're probably very familiar with these already, but just wanted to definitely remind you to keep your eyes on the FORP newsletter and the FCC CARES funding. And then there's probably going to be others coming for broadband access. And there most likely will be a stipend coming for devices. So I'm going to pause there. I'm going to hand it over to Matt, and I see that there's a bunch of things in the chat box. So while Matt's presenting, I'll go through those, and if there's any that I can answer, I'll jump on that.
Okay, thanks, Nikki. Yeah, there were some good questions about when the public health emergency will end and how long the waivers will be in place. And it's definitely a challenge to keep tabs on right now because it's changing so much. And I'll just mention too that the federal waivers are basically in place with the public health emergency, but the state waivers and emergency declarations are changing all the time. We were on a call yesterday with some folks in Alaska who said that on Valentine's Day, a lot of the regulations and waivers in Alaska just ended. The governor ended them, and everybody's scrambling to figure out what that means and how to react. So just important to remember to try to keep on top of what's happening within your individual states as well. So I just have a couple slides, and my goal is to take what Nikki shared about telehealth basics and try to make it more applicable to a flex program. We do a lot of presentations for healthcare providers and healthcare systems, and so that's usually the audience we're talking to, but we understand who you are and flex programs, and that you're in a different situation where you're supporting hospitals and clinics, but don't have direct responsibility for patient care or telehealth. So I've used this slide a few times to summarize some of the things that Nikki shared about what drives the adoption or lack thereof of telehealth. And it usually always kind of comes back to reimbursement. So understanding how Medicare reimburses, as Nikki mentioned, previous to the public health emergency, telehealth had to be done in a rural area. Rural health clinics and FQHCs weren't considered distant site providers. And so those policies and regulations for reimbursement hindered the adoption of telehealth. And then along comes COVID-19 and the public health emergency, and all these waivers are in place. So let's speed everything up. Let's allow telehealth to be done in rural and urban areas in basically any area, whether it be, a hospital, a clinic, an FQHC, in the home, whatever it might be. They also, had waivers in place for technology, not having to use a HIPAA compliant platform. One of the things I mentioned in the chat was that a problem or challenge that's arisen because of that is within a hospital or within a healthcare system, individual providers or different specialty clinics within that hospital were signing up for different platforms. So even within one hospital or system, there's multiple platforms being used, which confuses patients and providers trying to figure out all the different technology. And then one of the other biggest things we've seen is access. So broadband, when I say access, I'm talking about broadband internet connectivity, both in the hospital or clinic and in the home, because the method of delivering telehealth has changed so much because of the pandemic, where it used to be the patient was at a clinic speaking with a specialty provider at a remote hospital. And now we're seeing situations where both the patient and the provider are at home, and both need good internet connectivity and a good platform to use. Thankfully, the provider can be reimbursed when they're at home or the patient's at home. But all those things that used to be some of the barriers that kind of like driving through the mud a little bit to to adopt and sustain a successful telehealth program. They're changing all the time. Provider and patient engagement. I think everybody was kind of forced to use telehealth right away last year. And now it's really trying to understand, how do the providers like it? What are the challenges that they're seeing? And also the patient satisfaction. How do we keep them engaged? There's this great article that Nikki referred to about patients using social media, playing video games, driving their car, doing other tasks while they're on their telehealth visit. And so trying to educate patients and providers helps in that adoption of telehealth. Let's go to the next slide, Nikki. So I'm going to talk more now about how this applies to you, Flex programs, what you can do. So this may sound really obvious, but in general, really understanding the telehealth needs of your CAHs and RHCs in your state. So how much telehealth are they doing? We're seeing hospitals and clinics plateauing at about a 15% rate of all their visits being done virtually. If it's a mental health, behavioral health, or substance use type clinic, that's much higher. It's plateauing at about 75%. So just being aware, talking to them, finding out how much they're using, what platform they're using, is it HIPAA compliant, what type of services they're offering. During the public health emergency, they've expanded, as Nikki said, to a lot of different types of services like physical, occupational therapy, speech therapy. And so are they using it for that? Just being aware of that. Do they want to expand and do more remote patient monitoring? A lot of the funding that's coming out, especially from the FCC, is specifically for remote patient monitoring. They call it Connected Care Pilot Program and other funding programs to get patients connected in their home and electronically transmit that health data back to the provider. So supporting them with funding opportunities is a great thing that Flex programs can do, understanding what funding opportunities are out there. And we're trying to help. We have a page of funding opportunities on our website, and we can help explain those programs and how to be successful in applying for them. Understanding your state laws and requirements for licensing. One of the most common questions that we get is from out-of-state providers wanting to know if they can do telehealth in the state where the patient is located and if they have to be licensed. So just being able to talk to your licensing office and know those basic answers is a huge benefit. Funding workshops or webinars on billing and specifically for how to bill for telehealth services would be another great thing that a Flex program could do. Understanding the provider engagement, why are they hesitant if they are they getting reimbursed for those services, patient engagement and satisfaction, and how they're building telehealth into their workflow. And the TRCs have a lot of documentation and resources on how to do that if you're hearing from hospitals and clinics on how they successfully build it into their workflow. We're happy to help with that. All right, let's go to the next slide. So how can it impact finances? So the next couple of slides were really challenging because I was thinking about this, and it's kind of like we're in the fire and we don't know how big the fire is because we're right in the middle of it. So time will tell how much this move to a more virtual environment will impact finances. But if you think out of it in terms of 15 to 75% of all healthcare being provided virtually now, there's a guarantee that it's going to have some impact on finances. So it's really important. Are we billing correctly? Are we utilizing it for the most appropriate services? We often talk about the word parity. Is there parity in your state? What that means is in your state, are providers paid for telehealth visits the same amount that they're paid for in-person visits? One of the trends we're seeing right now is states creating bills, passing laws for parity, but it's a little scaled back. A number of states are creating parity laws for mental and behavioral health and substance use disorder only, and then allowing all other telehealth visits to be reimbursed at a contracted or negotiated rate with the payer. So some states have total parity, so all types of telehealth are paid for the same in-person rates, but not all do. But it's kind of a step-by-step process. So understanding how billing has changed for rural health clinics and FQHCs. So they used to not be able to bill as a distant site provider, and now they can. In the past, they used to be able to bill an originating site fee. It was a small fee, like $25 or somewhere in that range. So if they're not getting that fee anymore, are they billing as the distant site provider and getting the full reimbursement? So like I said, a lot of this is still yet to be figured out, but I wanted to share these bullet points as just to generate some ideas, generate thoughts about how will this move to a more virtual environment impact hospitals and clinics in your state. And then likewise, if you can go to the next slide, Nikki, quality. So how can telehealth improve quality? Well, we think it can in a number of ways. There's a great resource, if you haven't seen it yet, from RHI Hub, their Rural Telehealth Toolkit. One of the modules covers strategies to increase access to care in non-healthcare settings. And I really liked what they had. Talks about care transitions, so post-acute care, even post-surgery care, chronic disease management, as well as education. So diabetes management education and hypertension education. Direct caregiver support. EMS is a really interesting one. There's a lot of discussions about how to use telehealth both pre and during transport for EMS agencies. The number one challenge that I'm hearing is connectivity. So how do we have a reliable connection inside an ambulance to, let's say, bring in a stroke specialist and help provide remote care in an ambulance during transport. So that you may hear more discussions about that. But the other ones were medication adherence, medication management in general, home-based care for older adults. So we took the list of MB-QIP measures and thought we'd just go through them and look at some of the measures that might specifically be impacted by a hospital, by a clinic doing more telehealth. So patient engagement, communication with doctors, communication with nurses, communication about medicines and the transition of care back to home. A lot of that can be improved and be done via telehealth. Also care transitions. So I already mentioned medication management, reducing readmissions. I talked to an ENT specialist recently who said that they are really happy with their telehealth technology, and they're doing basically most of their follow-up treatment with telehealth and reducing readmissions, reducing complications, hospital return days. So just things to be aware of. How will this shift impact both finances and quality outcomes at our hospitals? And then lastly, maybe the most challenging one is the shift to value-based care and population health. We know telehealth can increase access to care. We know it can help manage chronic diseases remotely. I talked about education, Project Echo, and that model of using technology to increase provider education, especially in specialty areas. And then the last 2 points I think are really important in this transition to value. Telehealth should be held to the same standards of care, the same quality as in-person care. And so how do we ensure that? I think this is an area where there's still a lot of opportunity, a lot to develop content and material on how we do that. I was recently asked to speak to the Health and Human Services Department in the state of Utah, the legislature, on standards of care and appropriateness. What are the most appropriate services, and having the provider decide, is telehealth the right tool, the right modality to provide this service? So just some things to keep in mind. These aren't the answers, but things to keep in mind about how telehealth will impact the transition to value. So we also just want to let everybody know we have an upcoming annual virtual conference, April 21st and 22nd. It's focusing again on this COVID-19 pandemic, and we call it Telehealth's Big Bang. It's challenge to opportunity. And if you're interested in that and the speakers and the sessions that we have, you're welcome to register for it on our website. So I think that wraps it up. We can end there and turn the time back to Nicole and answer any other questions that anybody has.
Did anybody have any questions for Matt or Nikki on any of the content they talked about, or anything else that you might be thinking about as you heard what they were talking about?
Nicole, this is, I'll start. I'm extremely excited about the potential here for rural health. And I really want to thank Nikki and Matt for joining us today. And as Nicole has said, our intention is to support the TRCs and to make sure that all of our Medicare Flex programs, and to the degree we can, our hospitals and clinics really understand the resources that are available in those centers. One of the things that's very concerning to me is the whole issue of virtual care in general. And so I think we've been giving a real gift to be able to actually go directly into the homes. And that piece needs to be sustained over time, because we know there are a number of new competitors coming out of the woodwork here. Teledoc presents a mechanism to go around your local hospital and your local clinic. And we see increasingly that their presence throughout rural America. We also know that Amazon is intent on getting this market, that CVS intends to do telehealth directly into the home as well. So we have to be concerned about that. And then another feature here is the bigger health systems, which might have been way too remote to provide services up to Alaska or Montana, for example, now could be operating out of virtually perhaps anywhere in the United States. particularly if we don't put restrictions in place. And ideally, we keep the flexibility built in. But I really think that it's imperative that rural hospitals consider this aspect of their future. They don't necessarily have to create all these telehealth resources themselves, but they need to be aware of them, and I think build them into their strategic plans, find partners who can provide the services. And I know everybody is totally got a full plate at the moment, but this piece I think is really important. And again, I just want to express my appreciation to Matt and Nikki.
So Terry, one thing that I would be interested in is, you know, the reason you and I kind of started having a lot of these conversations and started thinking about wanting to work with the TRCs and present some of this content was we just weren't really sure how much the flex programs do turn to the telehealth resource centers, or even remember to turn their hospitals to the telehealth resource centers. I talked to somebody earlier who said they had a question from a hospital and they went to somebody in their state, and that's fine too, that's another resource. But I was interested in hearing from other flex programs and state offices of rural health about how much they work with their TRCs. And hopefully Nicole Brenton is ready for this. I talked to her earlier and she agreed to share a little bit about what they're doing in Maine with their telehealth resource center.
Hi, Nicole. This is Nicole Bretton from Maine.
Hey there.
Great presentation. So in Maine, we have a long-standing history working with our New England Telehealth Resource Center. Actually, I'm on their advisory board. We meet once a month. But through our history, especially in regards, we work with them on a whole array of resources, whether it's school-based care, oral health care. But for this, what we have done is worked with them for our Flex program in regards to, they have developed educational webinars, mostly pertaining to revenue cycle management, billing and coding for our hospitals. So that was a whole series that we worked with them and put together to them. As some of you are aware, in Maine, we work in networks with all of our hospitals. So our CEOs, CFOs, quality improvement, nurse managers, and nurse executives, they are usually part of our network meeting and agenda. So, you know, before we went into Zoom world, they would always be there to, whether it's financial, to be able to answer questions or technical assistance at our meetings. And they still do that. It's just mostly in through the Zoom meetings. One of the other things is they have established specific office hours for our rural hospitals. So they have an allocated number of hours that are designated that our rural hospitals can inquire, ask questions, technical assistance, whether it's about platforms or policies, anything around that. So we've actually started, we were able to establish that. So we work with them closely and they've been a wonderful resource and a great partner to work with.
Great, thanks Nicole. Thanks so much for coming on and sharing that. Terry, did you have any things you wanted to wrap up with, or did anybody else have any questions? I saw Jill put a comment in the chat that about the Southwest Telehealth Resource Center and how she's going to go talk to them a little bit about MB-QIP. So that's great that Matt helped us get started thinking about this. And like I said, we'll have another webinar in March sometime. I'm getting the details figured out to get more into that. We kind of went over the top of it a little bit, but we'll get more into that in March. So.
Well, I'd throw another comment just following up on Matt's comment about the value-based models and why telehealth is going to be important here. So again, in these value-based models, we're going to be trying to contain cost. And kind of in that regard, what we're finding is that telepsych, for example, is less than 50% as costly as in-person visits. And in fact, we had a conversation on our last coalition meeting about whether or not an in-person visit is going to be required if we're using telepsych. And our expert, who's done a ton of telepsych from the University of Colorado, was commenting that, in his opinion, the telepsych was basically just as good, and that in essence, it provided a means to get out to remote areas of the United States. So the cost factor plays really big here in the value-based models. And if we can assure, which is, again, we need the assurance that the quality is going to be good as well. But the cost itself, I think, is going to prove very popular for our value-based models. And I think that's another important consideration. A lot of the accountable care organizations and other organizations that are in an ACO or global budget model, I think are increasingly going to turn to telehealth because of the quality and also because of the cost.
Nicole. Hi, Neil Newberger here, and I would just throw out my 2 cents. Great call, Matt and Nicole. You know, also, as you look at all these programs and we look at the Internet of Medical Services and things, whether it's remote patient monitoring or telehealth or interoperable EMRs, we're increasing exponentially the number of potential attack surfaces that nefarious actors can access one way or another. And that increases exposure for man-in-the-middle attacks and ransomware attacks and denial of service attacks and that kind of thing. And so it's just something else in the policy, sort of internal policy sphere, you know, to sort of get on top of, and especially knowing that a lot of rural healthcare organizations don't necessarily have that capability to do that kind of, you know, security testing and assuredness that larger organizations do. Just something to keep in mind.
Oh, great. I posted in the chat about the telepsych comment. Dr. Robin McCardle is actually, I think, in the audience with us still, and Nick Galvez from the North Carolina Flex program. They had some really great success and a really great example of a telepsych initiative that Flex supported. I don't think Flex still supports it, but it is still ongoing, and it's definitely something Flex used to be involved in. So if that's something any of you are interested in, let me know and I can connect you with them in North Carolina so you can hear more about what they've done and what they continue to do with that. Okay, any last questions? We're almost at 3 o'clock, right at the top of the hour. Okay, well, thank you, everybody. Thank you so much, Matt and Nikki and Jolene for joining us, and Neil for your comments. And this recording will be available in about a week, and we will send you all an email and let you know when it's available. So thank you very much and have a good day.